Now we've got a slide with a number of different intestinal disorders for you to be aware of. First up are adhesions, which are a common result of surgery and are a fibrous band of scar tissue. They are the most common cause of small bowel obstruction. You can see an example one here. There may be as well demarcated necrotic zones. Next is angiodysplasia. This is where a tortuous dilation of vessels leads to bleeding. It is common in the cecum, terminal ileum, and ascending colon, and they're found in older patients. We can see one here. Duodenal atresia is another disorder associated with Down syndrome. This causes early bilious vomiting with proximal stomach distension due to failure of a recanalization of the small bowel. There is a double bubble sign on X-ray, which you can see here. With diseases like these, it is very important to keep track of whether or not the vomiting is bilious or not, because then you'll know if the patient's illness is proximal or distal to the duodenum and the insertion of the biliary system into the GI tract. In this case, vomiting is bilious because the atresia tends to be in the distal duodenum. Ileus is a disruption of the normal peristalsis ability of the GI tract, so there is intestinal hypomotility. It's important that this is defined as being intestinal hypomotility without obstruction. Ischemic colitis here is of a chronic variety. It is, as the name suggests, inflammation of the colon from reduced blood supply. The pain develops after eating, and therefore patients eat less to avoid pain and end up losing weight. The most common locations are at the splenic flexure and the distal colon. Can you remember why this is the most common location? Yes, that's right. This is the watershed area between the regions supplied by the SMA and the IMA. It is more common in the elderly. Meconium ileus is a common presenting sign of cystic fibrosis. What happens is that a meconium plug obstructs the intestine, thus preventing stool passage at birth. Cystic fibrosis affects the CFTR, which regulates sodium and chloride movement across epithelial membranes, including in the intestines. Necrotizing enterocolitis, or NEC, is a major complication in neonates. There is necrosis of the intestinal mucosa and possible perforation. The colon is the most common site, but it can involve the entire GI tract. This is very important disease to know because it affects neonates who have decreased immune systems, and NEC is potentially life-threatening. The classic radiographic sign is pneumatosis coli, which means there is gas in the bowel wall. Now that we've covered some of the other intestinal disorders, we'll move now to colonic polyps and then to colorectal cancer. The simple definition of a polyp is a mass that protrudes into the gut lumen. They often have a sawtooth appearance on histology, and 90% of polyps are actually non-neoplastic, but when found on colonoscopy, they are removed or biopsied to be certain. They are more common in the rectosigmoid area. Now, because colon cancer is an adenocarcinoma, the polyps that are precancerous are the adenomatosis type. There is a greater risk of malignancy in a larger polyp, which makes sense since there's more growth, as well as a greater risk of malignancy with villous histology, and as epithelial dysplasia increases. A mnemonic you can use is that the more villous the polyp, the more villainous it will be because of its chance to cause cancer. Here we can see an example of a villous adenoma, and here a tubular adenoma. There are three special forms we'd also like to mention. The hyperplastic polyp is the most common non-neoplastic polyp, with over 50% found in the rectosigmoid colon. Juvenile polyps, on the other hand, are sporadic lesions in children less than 5 years old, and fully 80% are found in the rectum. If there is just one, it's not malignant. On the other hand, though, when multiple are found and juvenile polyposis syndrome is diagnosed, there is an increased risk of adenocarcinoma. The Peutz-Jeghers syndrome is an autosomal dominant disease with multiple non-malignant hamartomas throughout the GI tract. Patients often have hyperpigmented mouth, lips, hands, and genitalia. This genetic disorder has a high risk of colorectal cancer and other visceral malignancies, such as pancreatic and breast cancer. Colorectal cancer we'll cover next, and it's a massive topic of great public health relevance. We'll try to hit some of the high-yield points here. Colorectal cancer, or CRC, is the third most common cancer in the U.S. and also the third most deadly. Most patients are over 50, and about a quarter have a positive family history. There are various genetic syndromes that give a predisposition to colorectal cancer. Familial adenomatosis polyposis, or FAP, is an autosomal dominant mutation of the APC gene. The APC gene is on chromosome 5q. Patients have literally thousands of polyps throughout the colon, usually including the rectum. The two-hit hypothesis in its simplest form is that one mutated allele is inherited, and sometime during life the other allele is either deleted or mutated, leaving no functional gene. Colon cancer here is pretty much assured. Gardner syndrome is when patients have FAP and also osseous tumors, soft tissue tumors, and congenital hypertrophy of the retinal pigment epithelium. Turcot syndrome includes FAP and malignant brain tumors. To help remember this for the boards, think of a turban wrapping around the head. Turban for Turcot. The genetic cause you may most be familiar with is HNPC, or hereditary non-polyposis colorectal cancer, also known as Lynch syndrome. This fact is often looked over because the acronym is so catchy, but remember that the name specifically says hereditary non-polyposis, meaning there are no precancerous polyps. Instead, small adenomas in the colon, which are easily overlooked on colonoscopy, can harbor advanced cancers that would usually only manifest in large polyps. Lynch syndrome is autosomal dominant and involves mutations in the DNA mismatch repair machinery. What other major type of cancers also show an increased rate in patients with a defective DNA repair enzyme? That's right, remembering back, breast cancer, which is more common in those with BRCA1 or 2 mutations. In HNPCC, around 80% progress to colorectal cancer, and patients with Lynch syndrome are at a high risk for many other types of tumors, which makes sense since they have a DNA mismatch repair defect. The proximal colon is always involved. We went over some of the risk factors already: IBD, villus adenomas, juvenile polyposis, and Peutz-Jeghers syndrome. Some other risk factors are strep bovis infection and tobacco use. The strep bovis connection is so important that if you see a question that includes the words strep bovis, look for an answer choice about colorectal cancer or colonoscopy for CRC screening. This is a particularly important fact: the presentation of left-sided versus right-sided colon cancers. Remember that left side obstructs, right side bleeds. Or more specifically, cancers in the distal colon cause obstruction, colicky pain, and hematochezia, whereas cancers in the proximal colon cause dull pain, iron deficiency anemia, and fatigue. Regarding diagnosis, the classic teaching is that iron deficiency anemia in older males is colorectal cancer until proven otherwise. Patients over 50 should get fecal occult blood tests and colonoscopies. A barium enema in advanced cases might show an apple core lesion, which you can see here. An apple core lesion has a narrowing of the bowel. CEA is a tumor marker that is positive in many cases, though it's not useful for screening. Clinicians often get serial measurements of the CEA to follow response to treatment, although this has not always been shown to be completely accurate. Okay, let's do a flash quiz. A patient is found to have thousands of polyps on colonoscopy. He has a history of bone and soft tissue tumors. What syndrome is suspected? That's right, it's Gardner syndrome. Remember, Gardner syndrome is an autosomal dominant disease characterized by polyps in the colon with tumors outside the colon, especially osteomas, thyroid cancer, epidermoid cysts, and fibromas. Let's now go through the molecular pathogenesis of colorectal cancer. There are basically two different pathways. Microsatellite instability accounts for only about 15% of cases, while chromosomal instability is implicated in the majority. The microsatellite instability pathway is when DNA mismatch repair genes are mutated, either sporadically or in the Lynch syndrome. The chromosomal pathway involves mutations of APC and beta-catenin. Here we have the standard molecular progression. We start with a normal colon, and when the APC gene is mutated, the colon is now at risk. Loss of APC leads to decreased intercellular adhesion and increased proliferation. Then, if there's a mutation in KRAS, intracellular signal transduction becomes upregulated. This is the point where adenomas form and can be discovered by screening. After APC and KRAS are mutated, the last step is loss of p53. At this point, there is increased tumorigenesis and formation of true carcinoma. Do you remember which genetic disease involves deletion of p53? I'll give you a hint. It leads to development of many different types of cancer at a young age. That's right, it's Li-Fraumeni syndrome.